Intravenous therapy, blood product transfusion. Blood products are transfused to restore and or maintain fluid volume, improve the oxygen carrying capacity. Each unit of PRPCs is expected to raise the hemoglobin 1 gram per deciliter, replace deficient blood components, assist with coagulation, and it can also prevent cardiogenic shock and help maintain hemostasis. Criteria for transfusion used to be we gave it whenever they had low blood vessels, but now it is not given automatically with low blood levels. Symptoms that prompt a transfusion will include shortness of air, tachycardia, low blood pressure, chest pain, lightheadedness, and extreme fatigue. Blood products will come in several forms. It can be administered as a whole blood, but due to the decreased potential or to decrease potential transfusion reactions or complications such as fluid overload, whole blood is often administered in specific products. The first one is packed red blood cells. Each unit contains about 200 to 225 mLs. Plasma will be removed from the blood with the packed red blood cells. It is indicated for fluid replacement, anemia, a low hemoglobin and hematocrit, symptomatic low blood levels such as hypotension, dyspnea, etc. We administer this over 2 to 4 hours. Plasma, also known as FFPs or fresh frozen plasma, contains albumin, fibrinogen, and coagulation factors. It's indicated for fluid replacement, hypotension, and coagulation deficits. This can be infused as fast as the client can tolerate. The next component is cryoprecipitate. This contains only fibrinogen and factor 8, 13, and fibronectin. It can be further separated out from plasma and administered alone. It's indicated in factor 8 and or 13 deficiency and fibrinogen disorders. Again, this can be infused as fast as the client can tolerate. The usual dose is 10 to 20 units. Platelets. It's indicated when the platelet count falls below 20,000 cells per millimeter cubed. Platelets are commonly ordered in 4-packs or 6-packs, and each pack will contain about 60 mLs. Again, this can be infused as fast as the client can tolerate. Granulocytes, remember those are going to be white blood cells, are indicated for serious infection that is not responding to antibiotics. To bone marrow that's not making granulocytes but will eventually be able to produce again. Albumin, also known as protein, might be stored in the pharmacy instead of the blood bank, and this is indicated for poor healing. It can also be administered in the event of significant third spacing to help pull fluids out of the tissues back into the blood vessel. Lipids, also known as fat emulsions, might be included in parenteral nutrition, but not necessarily. These also may be stored in the pharmacy. They are indicated in a fatty acid deficit or decreased energy. Nursing interventions. The client has to have a type and cross match. At this time, when the lab comes to draw that type and cross match, they're going to place what's called a blood band on the client's wrist. And this has specific numbers that will be associated with the client for the duration of their hospital stay. These numbers will then be attached to all blood products for that client. Always infuse blood products with normal saline. It cannot be infused with anything else. Blood products have to be initiated within 30 minutes of retrieving from the blood bank in the lab. Each blood container is going to have a label that identifies the product, the expiration date, and the blood type with the RH factor. In addition, it will have a blood bank label that identifies the product after type and cross match is completed with the specific client. Sometimes we call this a tag. Make sure that you confirm the client's IV site with the appropriate sized catheter is in place and is patent. Obtain vital signs prior to administration. Then a bedside check with 2 licensed professionals, that does not include a student nurse, compares the product information with the tag that's attached to the product and with the client. This includes checking the recipient's name, the ID number, and the blood band number, the type of component, the AB and RH factors, the expiration date, and checking the component for leaks, clutter, color, clarity, or signs of contamination. Most blood transfusions will come from donors, which is termed allogenic, but clients can self-donate, which would then be called an autologous transfusion. There's 4 types of blood, which consists of types A, B, AB, and O. There's also an RH factor, which is either positive or negative, and this is determined by the presence or absence of the D antigen. Due to type O blood having no A, B, or D antigens, type O negative blood can be given to anyone in an emergency, regardless of the blood type or RH factor. So it's called the universal donor. Due to type AB blood having no A or B antibody, these people can receive blood from anyone. They're called the universal recipients. Now there is a little caveat there. If they do have a negative D antigen, so they're AB negative, then it does have to be negative blood. In most states, LPNs are not allowed to initiate a blood transfusion, but they are allowed to monitor the client while they are receiving the transfusion. Policies for administering blood products will vary, so it's very important to be familiar with and follow your institution's policies. Once again, prior to transfusion of any blood product, we draw a blood sample and we send that for type and cross match. That's done to prevent or reduce the risk of an antigen/antibody reaction. The typing will determine the ABO and RH factor of the client. The cross-matching is going to check for antibodies in the recipient's blood that may react to antigens in the donor blood. We have to obtain an informed consent prior to per facility protocol and prior to the administration of any blood. Make sure you obtain client IV access. Peripherally, you need at least 20 or 22 gauge, but a 24 gauge can be used if necessary. If we need to administer this blood product rapidly, we should probably use a larger gauge, such as an 18. All central lines can be used for blood transfusions. Make sure you obtain the blood administration set. These have a built-in filter, so it's going to filter out any clots or impurities. Excuse me. Well, not necessarily impurities, but definitely will filter out clots. It might be a single set that has one spike, or it may have a Y set that has two spikes, where we connect the blood to one spike and normal saline to the second spike. The administration set has to be changed at least every 4 hours or after each unit of PRBCs if it is run over 4 hours. Normal saline, once again, is the only solution to be used in the administration of blood products. Some healthcare providers want you to pre-medicate the client. So sometimes that will include acetaminophen or diphenhydramine that decreases some of those little minor temperature elevations or itching. Obtain 1 unit of blood from the blood bank. Never obtain more than 1 unless it's an emergent situation and you're going to be transfusing multiple units at the same time. That does not happen except in an emergency. The unit of blood has to be initiated within 30 minutes of receiving it to the nursing unit. Again, check that blood component against the orders. Then again at the client's bedside with a second licensed professional, matching the following to what is on the blood ticket attached to the unit per facility protocol. Again, the recipient's ID number, their name, the blood component ID number, the type of blood component, the AB and RH type, the expiration date, making sure that the component looks normal. There's no clots or discoloration, gas, or cloudiness. The container has no leaks. Get your pre-transfusion vital signs and then per facility protocol. For example, every 5 minutes for 15 minutes, then every 30 minutes following transfusion up until you've reached that 1 hour mark. It just depends on your facility protocol. So at least 15 minutes after initiation, vital signs should be obtained. Transfuse per recommendations or orders. Again, look at your facility protocol. Your PBRCs should start slowly for 15 minutes, and then you transfuse at a rate to be completed within 4 hours. All other components can be administered at the ordered rate from the beginning. FFPs go over 1 to 2 hours. Cryoprecipitate will expire after 6 hours. The blood product unit has to be checked. Initiate within 30 minutes. If you cannot initiate it within 30 minutes, it has to be returned to the blood bank. Get your vitals before administration and per facility policy. You have to use a built-in filter in the blood tubing. Stay with the client at their bedside for at least 5 to 10 minutes after initiation to observe for reactions. If we are administering blood rapidly, we can use a blood warmer. Pressure bags in emergency situations can be used to increase the rate of flow of the blood. And again, pre-medicate as ordered. Never add medications to any blood component. Never transfuse if there are any discrepancies noted during the checking of the component. And never piggyback blood products into any solution other than normal saline. Again, vital signs obtained before the start of the infusion and then at least 5 to 15 minutes after initiation or per your facility protocol. Excuse me. Always monitor the insertion site. and observe for side effects. Fever, chills. Chills are not to be confused with being cold. People can be cold just because of the environment. Chills are usually the result of a fever. Rigors, headache, nausea, facial flushing, a rash, back pain, and dizziness are the main complication or side effects you may notice. If you notice side effects, stop the infusion immediately. Disconnect the administration set and connect a new set with normal saline to the IV catheter. Obtain vital signs. Obtain a urine sample. Have lab come draw a blood sample. You may need to get that urine sample to send with them. Notify the healthcare provider of the condition and treat this client's symptoms. Return the blood bag with the ticket and the administration set, including the normal saline, to the blood bank because they will do testing on it. Be aware, though, that mild reactions may not require discontinuation of the unit. In other words, we have a client that started out with a temperature of 98.9 and now they're at 99.3. That's just a mild reaction. If they're not having other symptoms, we may need just to slow down that transfusion rate, but let the healthcare provider make that decision. And it may require medications just to treat those symptoms. With all clients, but especially your older adults, always monitor for fluid overload. There's several types of reactions, but there's three main reactions that we discuss in this course. The first one is hemolytic. This is caused by incompatible blood. It can result in renal failure and shock, and it can be life-threatening. Febrile reactions are caused by the client's antibodies reacting against antigens to the donor's white blood cells or platelets. It causes flu-like symptoms, chest pain, and hypotension. And allergic reactions. This is caused by an allergen that's present in the transfused blood, causing hives, itching, fever, chills, facial swelling, wheezing, and/or sore throat, and could potentially lead to an anaphylactic reaction.